So I'm going to discuss a case, and this case actually would open up a whole new topic, which is quite interesting because this is something that we don't very often see in pediatric practice. But nevertheless, sometimes when these type of cases they come across, you can be scratching your head, and there is a lot of like differentials which have to be kept in mind when we deal with these types of cases. So I will not disclose the case basically. That's why I've given a sort of a caption which makes you scratch your head, that it says what's hidden deep beneath this rash. So basically we are going to discuss a case, a pediatric case, which basically presented with a rash and a swelling. And we will be discussing how did this child present, what were the clinical features, how did we deal with this thing, and what it eventually turned out to be, and what are the different types of differentials which have to be kept in mind when we are dealing with these types of cases. So to begin with, I saw this case last week on Thursday, and this was a 5-year-old boy who was basically came with a handwritten letter from his GP, and was a well-looking child. Basically, when they booked in, they said like he has got a rash, and the GP saw him that day, and he said, "I don't know what this is, and I'll just give you a letter. You go to the A&E and get it sorted out there." So this was a well-looking child, a 5-year-old male, who had developed rash and a swelling. So the details is that he had developed a rash which was predominantly present on his lower limb. So the rash was present for the last 4-5 days. They said like it started on 4-5 days, and it was still in evolution. They said like every day, and now the rash is appearing here and there. And they said like more worried than the rash, they were about the swelling which had appeared on his left forearm and wrist. So he had a swollen forearm, painful swelling of the forearm, especially more so on the wrist and the hand, and he had a few like rash-like lesions on that particular area of the forearm and hand as well. And the mother was telling me that 2 days before this swelling of the left forearm and hand appeared, he had a swollen knee as well. So he said like 2 days ago he woke up and he was having a swelling of the knee, and he was not even able to weight bear. But then the swelling that day by evening went on its own without any treatment. The swelling went away, and after 2 days now the swelling appeared in the left forearm extending down to the left hand. And she said like when the GP was examining her forearm, and obviously there was no history of trauma, he said he could feel something beneath the skin. There was some like hard like lump beneath the skin. So he said like you need to go to A&E immediately. So while taking the history, I asked, okay, how did this all develop? They said like it started 5 days ago. So I said, okay, well, 5 days ago, was he fine? He said like, yeah, 7-8 days ago he had a cough and cold like symptoms. So he had a bit of cough. They were not sure if there was any fever or something, but he said that he eventually came out of that illness, whatever it was, like cough and cold, like probably a common cold. But like they said, it was a minor illness. He didn't even have like sort of a fever, and they were not worried about that. So he got over it, and then he came up in this rash. And they said even in the rash, they thought it might be something, maybe a sort of a rash, which usually comes up with viruses and other thing, it would go away. But they said the rash is not going away. They said they tried to do the glass test. The rash is still there. And then this swelling appeared. So I said, okay, let's have a look. So initially, when they were triaging, he was absolutely fine. All the vitals were absolutely fine. He was like a pop score of 0. He was afebrile. He was otherwise fine, looking happy. And as I said, this was a history and examination finding showed this thing. So let me show you the type of rash that he had. So here you can see this is the type of rash that he had on his lower limb. So it was like sort of a discrete papular purple shaped non-blanching rash, which was starting from the groin down to the lower legs. A few of the spots were more purplish in nature, with sort of a punctum in the center. I won't call it an ulcerated lesion, but they were quite dark in the center. All the lesions were, you could feel it like it was a papular. So when you put your hand on it, so you could feel the rash. A few spots were tender, especially the one on the like slightly above the ankles. They were a bit tender to touch. And then he had a swelling of his left forearm and wrist. The lesions were quite few on his hand, but it was quite painful. When I pressed it, it was, the child whinged with pain. Uh, he had a slight, like on the forearm, very like faint purplish lesion, again same type of rash, but that had a bit of subcutaneous induration as well, so I could feel like there was some subcutaneous thickening associated with that. Open up his mouth, there were no oral lesions. I couldn't find any like evidence of tonsillitis or pharyngitis. He hadn't had any lesion on the face, on the neck, or on the upper torso, though a few spots were here and there. And while I was re-examining him, the mom said, look, the few spots have come up more as well. So there were a few more like these papular non-branching spot which had appeared. So again, auscultated his chest, was absolutely clear, examined his abdomen, didn't complain of any abdominal pain, couldn't find any hepatosplenomegaly. So absolutely, in terms of examination finding, except these visual findings, everything else was absolutely normal. So this was the history, which I was also started scratching my head that what this could be. So with this history, with these examination findings, what do you think? I'm just asking you, like just trying to open up your mind at this point in time, that what could be the broad differentials or diagnosis based on this sort of presentation with a well child with these differences, with these examination finding. What do you think could be the underlying cause? Just asking if you can, one by one, if you just give me your like whatever you think about at this point in time. We haven't done anything, you have just seen the case just like me, you have examined, I've given you the history, I've given you the examination finding. What do you think could be the reason or reasons?
Could it be like an IgA vasculitis, like HSP?
Okay, number one, HSP. Yes, very good. And what makes you think about HSP? Like what in this differential is going in favor of HSP?
I think the limb swelling and the lower limb, like non-blanching lesions. Obviously, I think you get like abdominal pain, but I think, did you say they also had like pain in their joints as well?
Yes.
That's kind of the first thing I was thinking of.
Fair enough. Very good. HSP is the first thing that comes into your mind because that is one of the commonest things that you see in pediatric practice. Like relatively, with the non-blanching rashes, especially which are present on the lower limb, the most common would be HSP. And obviously, you said because it's predominantly present on the lower limbs, and it looks like HSP, so it could be HSP. Though you said okay, there are some other features which are missing in this particular case, but again, not everything is present in every type of every presentation of an illness. And but if you take an HSP, one thing which is present in 100% of the cases is the characteristic rash. So you're very fine. HSP could be one of the differentials and one of the commonest thing that can present this way. Yes, any other differential? Sorry, didn't I think your voice is like sort of intermingled with one another. Didn't hear what somebody said. Erythema nodosum. Okay. So erythema nodosum. Diana, what makes you think that this could be erythema nodosum? Like what are the features in this particular presentation which goes in favor of erythema nodosum?
Affecting the lower limbs.
Yes.
Mainly.
And they are tender as well. Like they are most painful, like lumpy presentation, or the lower limbs can present in various forms. Sometimes brownish sort of rash, sometimes a purplish type of rash, again depending on the underlying skin color. So yes, erythema nodosum, but erythema nodosum basically is not a diagnosis itself. It's usually a thing which is associated with many types of inflammatory disorders. And can you name a few inflammatory conditions which can present with erythema nodosum? Pardon?
Ulcerative colitis.
Okay, inflammatory bowel disease, that's fine. Ulcerative colitis, or like, what's the other one? The Crohn's disease. Any other like illness which can present with erythema nodosum? Hmm?
Tuberculosis.
Yeah, tuberculosis, and then there are variants: sarcoidosis, tuberculosis, mycoplasma infections. There are so many different, sometimes certain types of drugs can also be associated with that. So, like, yes, erythema nodosum. Any other differential that can be considered?
Kawasaki.
Yes, Kawasaki. Yes, very good, Kawasaki. What makes you think about Kawasaki?
Kind of similar with like the painful rash and like feeling unwell for the past 5 days.
Mm-hmm.
They don't have they didn't have any red eyes, but that was kind of like another differential for like these kind of rashes.
Yeah, you're also right in terms of, like, that can be one of the differentials, though. For Kawasaki illness, we have got a criteria. So there's a clinical criteria that has to be covered, that is like, fever, and there are a few other things that have to be present. But even sometimes, if those things are not present, still you can make a diagnosis of Kawasaki. We call it an incomplete Kawasaki, because presentations can be atypical. And yes, you are very right. Kawasaki illness rash usually presents on the peripheries. It can be painful, associated with swelling, and sometimes desquamation as well. Though there was no desquamation in this, but you never know. I mean, it's not necessarily that every case of Kawasaki illness would be presenting with desquamating rashes. Usually, desquamation is a late part, or thing in rashes. Once the rashes appear, they stay for some time, and then the desquamation starts. Like when the rash starts to clear up, then the desquamation phase comes in. So yes, Kawasaki illness. Anything else that you would be thinking when you see with a sort of a non-blanching rash on the lower limbs? Any hematological thing that could present with a non-blanching rash?
ITP.
Yes. ITP, okay, immune thrombocytopenia, that can present with a rash. I mean, most of the time, thrombocytopenia would present with a generalized rash, but well, I mean, depending, every individual is different. Some people who are quite active physically, it might appear on the dependent parts, because they are basically there will be more chances of some micro hemorrhages, and then resulting these subcutaneous sorry these the skin lesions, like a non-blanching rash. So by and large, mostly we see a generalized very small pinprick rash, which is usually non-painful. It's like a non-tender, but well, I mean, it can appear in certain areas as well. But one of the things that usually normally see in ITP is that the rash is never painful. It's not associated with the joint swelling, though. If something is coexisting, like with the hematological parameters, and because something else is causing that hematological disbalance, so that can also present in the form of arthritis or arthralgia. So yes, ITP can also present in this way. Okay, so we had a good discussion about the broad differentials that can come into your mind when you see a well child with this type of rash on the lower limbs, and with the swelling of one side, like one upper limb as well, which is extending from, like, one joint to the other joint, and has got some rash over that part as well. Now, what I did was, we tried to investigate to see if there are any underlying abnormalities in his blood parameters, and routine blood tests were ordered. His full blood count showed a normal white blood cell count. His thrombocytes were slightly elevated, so it means there was no thrombocytopenia. Rather, the thrombocytosis means that the thrombocytes were slightly on the higher side, so rather touching around 500,000. His CRP was very mildly elevated, 12.2. ESR was also borderline at 25. renal function, which is a very important thing to look for in any child who presents with a non-blanching rash, especially on the lower limbs. Renal functions is urea and creatinine were absolutely normal. The electrolytes were also normal. We did a coagulation screen as well, obviously, to see if there are any underlying hematological, like coagulation abnormalities. Though normally coagulation abnormalities would present in other ways. They're more like with mucosal bleeding and like bleeding into the joints rather than subcutaneous, like pinprick, painful rashes. A coagulation screen in terms of his PT, APT, INR ratio was absolutely normal. A urine dip was done, which showed traces of proteins, but importantly, there was no blood in his urine and no leukocyte esterase and no evidence of nitrate. So that was very much like non-specific, nothing over there. Now, seeing these results, what now differential come to your mind now looking at this? Obviously, something would come out of the equation, like for example ITP, but what do you think is happening here? What is this whole picture showing? I mean, it's not pinpointing a diagnosis, but it is actually pointing towards a pathological process. So what do you think that process is? Obviously, the most dreaded thing that people worry about when they've got a non-blanching rash, irrespective whether the child is ill or what, is like meningococcemia or something. But here you see a white blood cell count is absolutely normal. There's nothing over there. So we had done blood culture and later on it came out to be normal as well. So okay, so let me tell you, if you look at this blood picture, I mean, obviously this is not pointing, like, it cannot pinpoint a diagnosis. It cannot pinpoint a diagnosis, but what you are seeing is very mild increase in inflammatory markers, very mild. 12.2 is a borderline increase with a mild thrombocytosis. Thrombocytes, usually reactive thrombocytosis also occurs. So all the things are pointing towards inflammation, a mild inflammation somewhere. Mild inflammation somewhere. But that inflammation is probably not affecting the kidneys because you have got a normal creatinine and urea levels. The urinalysis is also fine. So most of the inflammatory disorders, there is a big group of inflammatory disorders. They can affect multiple systems. They can affect multiple surfaces, and they can affect multiple organs. And usually the one that is most commonly affected in inflammatory disorders are joints and kidneys. Now, joints, we can't do anything. We did x-ray of the right knee and the left forearm up to the wrist, but again couldn't see any for sort of a flare up in the, like in the joint surfaces. There were no erosions, nothing. Obviously that is not very specific because you can still have normal x-rays with the joint inflammation, especially in pediatric practice. Ideally, the most what you call specific thing would be to take a joint aspiration and send that fluid to see whether there it shows any increased white blood cell counts and things like that. Anyhow, but that's a bit like overkill in pediatric practice unless until you are thinking of septic arthritis or something like that. Obviously this was none of that thing because the child was normal in terms of his vitals. He was not having specifically joint issues, so basically a rash with some joint issues, so predominantly rash. So the thing is that here comes the caveat. So there is an inflammation. We need to know where the inflammation is. So if you think the inflammatory disorder or in whatever inflammatory condition is there If it was something like SLE, or if it was something like juvenile rheumatoid arthritis or sarcoidosis, what would you expect normally in that particular condition? You would be expecting multi-organ involvement. Multi-organ involvement. And there is another whole group of disorders which we classify as vasculitis, which is inflammation of the blood vessels. And because blood vessels are present in almost every organ, those organs can be affected. So number one, if thinking of inflammatory disorder, are we dealing with something which has got like a multi-system inflammatory disorder? No, probably not, because this child had got no difficulty in breathing. He's not presenting with asthma-like symptoms. He's not having any hemoptysis, not having any hematuria. He's not having any abdominal pain. He's not having any CNS involvement. All he has is a rash and some joint pain. So maybe the joints are involved and the skin seems to be involved. So whatever the inflammation is, it is confined at this point in time to these two organs. So going forward, the things that we can be, as I like earlier said, HSP, one thing. In HSP, you've got palpebral purpura, you've got arthritis. So these two things, like this non-blanching rash, painful rash, and pain, like 1 day history of pain in his right knee, and now pain in his left forearm and left wrist, could be underlying arthritis. It's usually associated with abdominal pain and renal involvement as well, though in this particular case, we didn't see any abdominal pain, we didn't see any renal involvement. So could be HSP? Well, maybe it can be early stages of HSP. Who knows? We talked about ITP. Well, I don't think ITP is in this particular condition, because in that particular case, the platelets should be low. In this case, the platelets were actually on the higher side, though he hadn't had any systemic symptoms, which actually, if there was, like, let's say, low platelets, and given the fact that he was otherwise well, we could have thought of ITP if the platelets were low, but the platelets are on the higher side. Meningococcemia, the one which everybody fears about, and especially I think the GP was also at the back of the mind. He didn't write that he was, his handwritten didn't say that he was suspecting this thing, but probably that was his fear as well. But that usually is associated with fever, and the child is very unwell. I mean, you can't, I mean, I haven't seen somebody with meningococcemia with where the rash is like evolving and they are very well. Like usually GCS would be low, some form of meningeal involvement or CNS involvement is there. SLE or other types of multi-system inflammatory disorders. You've got this now secondary to COVID-19 as well, what they call MSC or something to COVID-19, multi-system inflammatory disorder in pediatrics, or SLE or sarcoidosis. But they would be having something. So you would be seeing either a raise in liver enzymes, you would be seeing a mallow rash on the face, there would be some renal involvement, things like that. And usually there's, in case of SLE, they are positive to anti-nuclear antibodies, and especially the anti-double stranded DNA antibodies. And then there are some other types of inflammatory disorders, like the post-infectious inflammation of the blood vessels or drug-induced inflammation of the blood vessels, which you can think about. But by and large, this is an inflammatory disorder at the moment with these tests. So there is an inflammation going on which is affecting the skin and probably one or two joints. So as I said, HSP probably out of the equation because there is no renal involvement. ITP is thrown out of the window because obviously the thrombocytes are on the higher side. Meningococcemia, we don't think so, the picture is not fitting. SLE, don't think so, because there's not like multi-system organ involvement. SLE has got a whole criteria of 11 points, of which you have to like check mark, or there are usually it's related to multi-system disorder, but there is some form of renal involvement as well. Post-infectious vasculitis, could be he had a cough, we don't know. Drug-induced vasculitis, doesn't seem like he didn't take any like sort of medications like antibiotics or anything like that, which might have resulted in vasculitis. So the thing is that probably we are dealing here with vasculitis. Vasculitis means inflammation of the blood vessels. Even the HSP that you were talking about is a vasculitis. The only one thing is that is it IgA based vasculitis. So vasculitis basically is inflammation of the blood vessels, and it can affect any organ. It can affect multiple organs, it can affect single organ, and again it depends. So this is the Chapel Hill consensus criteria nomenclature of 2012. So we classify the blood vessels into large blood vessels like the aorta, and the big vessels which are arising like the subclavian trunk, the celiac trunk, things like that, the big vessels. Then you've got the medium vessels. Medium vessels are like renal arteries and things, small branches which are going into the organs, medium size basically. And then you've got these small vessels, small blood vessels, which are small arterioles, capillaries, and even the venous side of the blood vessel, that is the venules and small veins. So inflammation can occur because of any reason in the large blood vessels, it can occur in the medium blood vessels, and it can occur in the small blood vessels. So there are three types of vasculitis: the large vessel vasculitis, the medium vessel vasculitis, and the small vessel vasculitis. The large one are the Takayasu's arteritis, which basically is inflammation of the aorta, and giant cell arteritis, which causes headaches and everything. Usually rare in children, mostly occurs in adults, but these are inflammation of the large blood vessels. Then you have got the medium blood vessels, where inflammation can occur secondary to anything. And the one in pediatric practice which we commonly come across in medium vessel vasculitis, Kawasaki disease. But Kawasaki disease has got fever, it presents very much like sepsis, and it has got a clinical criteria, that is fever for more than 5 days. There should be non-exudative tonsillitis, there should be non-exudative conjunctivitis, cervical adenopathy, oromucosal lesions, or sometimes sort of a rash, polymorphous rash, especially on the extremities. The other type of medium vessel vasculitis is polyarteritis nodosa, PPAN. But polyarteritis nodosa is a rare thing, rarely happens in children, but sometimes you can think of polyarteritis nodosa in kids who have gone unexplained abdominal pain. So if somebody comes with a repeated history of abdominal pains, investigations usually in the past have turned out to be normal, but if you do their inflammatory markers, they are not febrile, but they're usually the inflammatory markers on the higher side, and they are having pain in the abdomen. And you're thinking, is it like infection or something? Can't be. Like infection in the intestine, should be presenting with diarrhea or something like that. There you can think of polyarteritis nodosa, because polyarteritis nodosa usually leads to abdominal pain because it affects the medium vessels. So postprandial pain with increase in inflammatory marker and severe pain. I mean that, and there is a history of recurrency to that. So you can think about that. So, but more common than polyarteritis nodosa is Kawasaki disease in pediatric practice. And then we have got the small vessel vasculitis, which have got so many conditions that can cause small vessel vasculitis. Now we have got the cryoglobulinic vasculitis, which is usually associated with cryoglobulins. That can happen sometime in mycoplasma pneumonia. We've got the IgA vasculitis, the common HSP, which is one of the commonest vasculitis seen in pediatric practice. So usually after some viral illness or something, there is IgA deposition in the blood vessels, leading to like inflammation, and these blood vessels, they usually then like sort of rupture with fibrinoid necrosis, leading to this painful subcutaneous rash-like lesions, palpable purpura as we call it, on the lower extremities. We have got the hypocomplementic urticarial vasculitis. That's, I don't want to go into detail of that, that's altogether a different subject. And then we have got some other types of illnesses, which usually small vessel, where there is multi system involvement. One is Wegener's. Wegener's is the old name. It is known as granulomatous with polyangiitis, and the other one is eosinophilic granulomatosis with polyangiitis, which is known as Churg-Strauss syndrome. So Wegener's, usually there it involves the sinuses, it involves the lungs, it involves the kidney. So basically they've got hemoptysis, epistaxis, and some renal involvement. The the other one, the eosinophilic granulomatosis with polyangiitis, that usually presents with asthma-like symptoms. So they've got high eosinophil count in their blood. So especially from practice point of view, if you are seeing an asthmatic child, I mean, not related with this topic, let's say an asthmatic child who develops every now and then asthma, and he also appears to be the same phenotype where eosinophil count is high, and you think is a history of family history of atopy as well. And the problem is they only respond to steroids. And I've seen cases where you can think of these things. You treat them as an acute asthma or viral wheeze, you send them home, they're fine for 3 to 4 days of steroid use. As soon as the steroids are stopped, still on the inhalers, they are back with the same symptomatology. That could be one thing, where one can think of eosinophilic granulomatosis of polyens, so Church-Strauss syndrome. So usually they would have some renal involvement as well. So in that particular case, it's important if somebody is not responding, just do a renal test to see if they are showing any sort of a hematuria or proteinuria or not, because if that is, then probably you are thinking of eosinophilic granulomatosis with polyangiitis, and usually on the face value it presents like an asthma. So asthma and renal involvement, we call it as Church-Strauss syndrome or eosinophilic granulomatosis with polyangiitis. These were the old names. We don't use Wegener's and Church-Strauss anymore. These are just both granulomatosis with polyangiitis. One is eosinophilic, the other one is non-eosinophilic. One is CNK positive, the other is PNK positive, which are the anti-cytoplasmic nuclear and autoantibodies. These are antibodies which actually hit on the blood vessels, okay, and destroy the endothelium of the blood vessels, and then leads to fibrinoid necrosis, and they can have like different types of symptoms. One thing which in small vessel vasculitis, which does not affect multiple organs, mostly affects skin. Because I'm coming down to in this particular case, we only see that the skin is involved and probably one or two joints, but nothing else. That is what we call as leukocytoclastic vasculitis. Leukocytoclastic vasculitis. Let me come to this one. So leukocytoclastic vasculitis. So what is leukocytoclastic vasculitis? Look at the word leukocytoclast. So leukocytes are your white blood cells. So what happens? Clastic means they're broken down. So usually what happens, for some reason, the white blood cells, they migrate to the small vessels, because this is a small vessel vasculitis. They move into the small blood vessels. There they attack the endothelium. They destroy the small blood vessel endothelium, especially the venules on the venous side, not on the arterial side, but on the venous side. They destroy it. And what happens? Because of that destruction, there is usually a fibrin dust around the what you call the cellular debris. So if we take a biopsy of the lesion, you would see that there is fibrinoid necrosis with nuclear dust. This nuclear dust comes because of the breakdown of the white blood cells, because white blood cells are attacking the endothelium, and in the process of attacking the endothelium, they themselves die. So they are just like suicide bombers who attack the endothelium and get destroyed themselves as well. So that destruction, I think that leads to painful purpuric rash, which you see on the skin, because venules are very close to the skin surface. That's why you get those like purplish spots on the skin, which we call as palpable painful purpura. So this is a small vessel vasculitis with immune complex depositions and white blood cell inflammation into the small blood vessels, especially the venule site. Why it occurs, nobody knows. Again, there are theories. Idiopathic means maybe your genetic predisposition is such that for some reason your immune system just goes haywire, starts attacking your own cell. It could be sometime post-infectious as well, especially associated with certain types of viruses, secondary to Epstein-Barr virus, secondary to hepatitis B and C virus, secondary to HIV virus, secondary to certain type of atypical organisms like mycoplasma. It could be drug related, especially cephalosporins can be associated with this, or it might be secondary to certain other type of systemic condition, systemic inflammatory condition. Now, in pediatric practice, Regarding leukocytoclastic vasculitis, there are two types that exist. Number one is the infantile form, which usually occurs in children 2 to 24 months. Some books say 6 to 24 months. This is known as acute hemorrhagic edema of infancy. Remember, the infantile form of leukocytoclastic vasculitis in infants or up to 2 years of age is known as acute hemorrhagic edema of infancy. And then we have got the childhood form, which occurs in elder children, and that is what we call as hypersensitivity leukocytoclastic vasculitis. Hypersensitivity leukocytoclastic vasculitis. And this particular case that I'm talking about, this 5 years old that I saw last week, was basically a case of hypersensitivity leukocytoclastic vasculitis. So he developed vasculitis. We don't know why it happened. He had a cough or cold, maybe some viral infection, and after that his immune system got haywire and he developed this condition, or it might be idiopathic as well. Sometimes you are not able to do. The most specific diagnosis is through skin biopsy. Unfortunately, from practice point of view, most of the time nobody does these things, because you need a dermatologist to take the biopsies and then send it for to histology for studying those things. By and large, most of the time the diagnosis is made clinically. So based on the clinical features, based on the initial investigation workup, ruling out the other conditions, you then narrow down your diagnosis to this particular condition. So this child had hypersensitivity leukocytoclastic vasculitis. How does the other one look? The acute hemorrhagic edema of infancy. I will just quickly show. So you look at this picture. So this, you can see that these are different pictures of child with the small, you see it can appear in many forms. It can appear in the form of small circular or annular lesions which are non-blanching with an annular rim. They mostly appear on any part of the body. It can be associated with edema of the associated organs. For example, you can see here he's got edema of the penile shaft and the scrotum. It can appear on the lower limbs. It can appear on the upper limbs. It can appear on the cheeks as well. So out of nowhere, all of a sudden, an infant develops these type of small to big annular lesions, non-blanching, or their skin. They are otherwise very well. They are not unwell. They are absolutely fine. Okay, it looks very scary because you've got all these big rashes appearing on your skin, and that's it. So this is acute hemorrhagic edema of infancy. Again, as I said, this is leukocytoclastic vasculitis. So there is an underlying inflammation of this. Idiopathic, secondary to viruses, secondary to drugs, nobody knows, but it's can. So this is the infantile form of leukocytoclastic vasculitis. Again, in the elder one, let me go back to take you to the images. Here is the one that I saw. So you can see that here small palpable purpura, okay, spots, papular spots, which some of them were quite painful as well, predominantly on the lower limbs, but also on the left upper arm. You can see there is swelling of the left wrist and the left hand as well, which was painful as I tried to press it up. But the child was otherwise absolutely fine. The inflammatory markers were slightly raised, but as I said, told you, there was no renal involvement, there was no liver involvement, there was no lung involvement, there was no abdominal involvement. So it was only the skin and possibly the joints that were involved. So two types of leukocytoclastic vasculitis, which is a small vessel vasculitis in children. Remember, two presentations. One is acute hemorrhagic edema of infancy, and the other one is hypersensitivity leukocytoclastic vasculitis. Okay, going back. So if you, let's say, I mean, now we have reached the diagnosis, but normally if you don't know what this is, you need to do a diagnostic workup, because without workup, as I said, like the well, I mean, there are so many differentials that you will have to consider. So you have to check the full blood count to see, because full blood count will tell you if there is an increase in the white blood cells or not, if the platelets are up or down. You have to check the inflammatory markers ESR and CRP. You also have to check for renal and liver function. So renal function test, liver function test, urine analysis to see if there is any renal involvement, especially tubular or anything, you have to look for that based on the urine analysis, and also if possible doing a proper like not the urine dip, but sending the urine for what you call this microscopy as well. And antibodies, so the problem is probably even if you try from the emergency department, if you try to check for their autoantibodies, they probably, even if you request it, they will not do that. Obviously I think it's more of something managerial, because probably the A&E doesn't pay them for these tests. So one very good screening test is the anti-nuclear antibodies test, which if positive can give you an idea if it could be SLE. Then there are other autoantibodies, especially the P-ANCA, C-ANCA, which are like a bit expensive, but they are quite like sort of a specific for certain conditions. Skin biopsy is very much specific. That confirms vasculitis via histology, but we rarely do these things. By and large, mostly what you will be doing, you will be checking for inflammatory markers, you will be checking for renal and liver function. You can also check for pulmonary function in the form of doing a chest x-ray to see if there are any sort of lesions on the chest x-ray or not, especially if the child is having cough or difficulty in breathing. And as I said, like well, you should know it, but normally you won't be doing these antibodies tests and everything. Okay, so clinical presentation of, as I told you, is leukocytoclastic vasculitis, a cutaneous form. Usually it appears in the form of this palpable, painful purpura on the lower extremities, but as I can extend to hands and arm as well, as we saw in this case that presented to us. There can be potential joint pain and swelling, like happened in this child. He had a 1-day swelling of the right knee, and then he had the swelling of the left forearm and wrist. And the important thing is that there is absence of systemic symptoms in isolated cutaneous leukocytoclastic vasculitis. So you don't see any systemic symptoms in the form of fever or abdominal pain or difficulty in breathing and things like that. As I told you, the only one thing that you'll find on clinical examination is that you'll be finding this non-blanching rash of various sizes, some of which might be painful, some of which might be non-painful. This is what we call acute hemorrhagic edema of infancy, which is infantile form of the same condition. So how do we manage this thing? So it's all about symptomatic management. So if there is an underlying cause, you would address that, but most of the time you won't find any underlying cause because it happens all of a sudden. For again, if there is joint pain, you have to give ibuprofen or diclofenac, depending on whatever is available to you. Steroids can be used for severe cases, or if there is systemic involvement, like for example, if there is renal involvement, or if there is let's say pulmonary involvement, then steroids can be given. 1 to 2 milligram per kg short courses of steroids does help. Dapsone is another medication that usually is quite effective in cutaneous leukocytoclastic vasculitis. The dose is usually 0.5 to 1 milligram per kg body weight. It's a good drug. The only one thing is that you have to be sure that the child is not G6PD deficient, because if somebody is G6PD deficient, you give them Dapsone, they will go in a crisis, like a hemolytic crisis basically. So Dapsone has to be given carefully. So a few days, 2 to 4 weeks course of Dapsone can also help. In very refractory cases where the steroids or Dapsone is not working, rituximab, which is basically a monoclonal antibody immunosuppressant, that can be used for cases which are not responding. And important thing is that, usually tell them that if the symptoms worsen, or the symptoms start like, crossing into other domains where like they start getting some renal involvement, other things, then they have to come back. So follow-up is very important, because vasculitis has to be followed up over a period of time, because there can be periods where the things, they wax and wane. So they start improving, sometime it can recur as well. The same goes for all types of vasculitis, whether it's Kawasaki disease, HSP or something. So they have to be under the radar screen. Like in HSP, we do like weekly follow-ups with the urine dip, and then like monthly follow-ups, and then 6 monthly follow-ups. The same goes for any type of vasculitis. You just have to monitor to see that the the number one, the symptoms are resolving. Number two, that there is no further involvement. So you tell them that what is the importance of the follow-up, even if they are doing it at their local GP.